Hello everyone and welcome to our module on intrapartum fetal monitoring. During labor and delivery, there are two standard elements of intrapartum fetal monitoring. The first is monitoring of the fetal heart rate. This is commonly done in one of two ways. The first is Doppler ultrasound, which can be placed on the mother's abdomen. The second is a fetal scalp electrode, which is an electrode directly placed on the fetal scalp through the cervix. This usually requires the membranes to be ruptured. The second element of intrapartum fetal monitoring is tochometry. This involves measurement of uterine contractions through use of a pressure catheter. And normally the results of fetal heart rate monitoring and tochometry are placed side by side like shown on the screen here. At the top we have the fetal heart rate monitor. You can see the heart rate is bouncing up and down between 120 and 150. At the bottom we have the results of tochometry. When the uterus is not contracting, the pressure is very low, but when the uterus contracts, the pressure rises like what's seen here. The normal fetal heart rate is 110 to 160 per minute. Bradycardia is less than 110 and tachycardia is more than 160. Brief accelerations in the fetal heart rate are very common when the baby moves. Just like when an adult runs around the block, their heart rate picks up. When the baby moves their arms or legs, that can increase the fetal heart rate. This should not be sustained, however. It will come back down to the normal range very quickly. And then decelerations in the fetal heart rate are very common during labor, and they're subdivided into three categories: early, late, or variable. So let's talk about that now. Early decelerations of the fetal heart rate occur synchronously with uterine contractions. This is an example of what one looks like on the screen here. So we have a uterine contraction identified by tochometry at the bottom, and associated with this contraction we have a temporary deceleration in the fetal heart rate. This is an example of an early deceleration because it occurs at the same time as the contraction. Early decelerations have a characteristic pattern, and you need to know this for your rotations. So early decels always have a slow onset. It takes 30 seconds or more to go from the onset of the deceleration to the nadir, and that's what's shown here. Also, as I already mentioned, the nadir occurs near the peak of the uterine contraction. And early decels are caused by fetal head compression associated with uterine contractions. When the contractions compress the head, there's a transient change in cerebral blood flow. This stimulates the vagal nerve, and that leads to a fall in heart rate. And these decelerations are generally benign and physiologic. They're very common in women during labor, and they don't require any special intervention. And here's another example of early decelerations, just to make this very clear. We have a uterine contraction, and synchronous with that contraction, we have a deceleration in the fetal heart rate. There's another one here associated with this contraction, and another one here associated with this contraction. In a late deceleration, the decrease in the fetal heart rate begins after the contraction onset, and the return to baseline for the fetal heart rate occurs after the contraction ends. This is an example of a late deceleration shown on the screen here. We have a contraction, and the onset of the deceleration is after the contraction has started. We then have a nadir and a recovery of the fetal heart rate back to baseline, but the recovery occurs after the end of the contraction. And so unlike early decels, late decelerations are not benign. They indicate transient fetal hypoxemia. They are caused by contractions that compress the blood vessels delivering oxygen to the fetus. They are an indication of uteroplacental insufficiency, and they require an evaluation of the baby and the mother. And we'll talk more about this later on. And here's an example of late decelerations just to make this very clear. The uterine contraction is here. The deceleration begins after the start of the uterine contraction, and the return to baseline is after the contraction has finished. Let's talk about fetal tachycardia, which, as we already mentioned, is when the fetal heart rate climbs to above 160. As I said before, fetal movements result in short bursts of sinus tachycardia that can be up to 200 beats per minute. These are a normal and benign finding, and they don't require any further investigation. In contrast, however, persistent fetal tachycardia does require a maternal and fetal evaluation. If you look at this tracing at the bottom of the screen, we have a number of uterine contractions along the bottom, but the fetal heart rate is persistently at about 180 beats per minute. This isn't a temporary acceleration. The heart rate is consistently at this level. That's persistent tachycardia, and that requires an investigation. There are many possible causes. The baby could be anemic, the mother could have an infection or a fever, and there are many other potential causes. The last type of deceleration is a variable deceleration. These decelerations have no relationship to the uterine contractions, which makes them totally different from early and late decels. Variable decels have an abrupt onset, and the time from the onset to the nadir is usually less than 30 seconds, which is shorter than for early or late decelerations. And just like late decelerations, variable decelerations are a dangerous finding. They represent a fetal reflex response to transient umbilical cord compression. So remember that early and late decelerations are caused by uterine contractions. In early decels, the uterine contractions are compressing the head. In late decelerations, the contractions are causing placental insufficiency. In the case of variable decelerations, they have nothing to do with uterine contractions. The umbilical cord is simply being compressed by the position of the baby in the uterus, so that compression can come and go randomly, unrelated to the contractions. Variable decels are also associated with oligohydramnios, and that's because when there's less amniotic fluid, it's easier for the cord to become compressed. And here's a zoomed in example of variable decelerations. We've got a couple of uterine contractions here, but then we have these decelerations that are unrelated to the contractions. We have one here, another one here, and another one here. And these are unrelated to the contractions because they have nothing to do with the uterus contracting. What's happening is the cord gets compressed by something going on in the uterus right here, and that causes the decel. It's unrelated to the contraction going on down here. If during labor and delivery a baby displays persistent variable decelerations, the first line intervention is to change the maternal position. Remember that these variable decels are caused by umbilical cord compression, so if you can change the mother's position, you can sometimes relieve the pressure on the umbilical cord. So one option is to ask the mother to shift to her left or right side. You can also try raising the knees to the chest, and in some cases mothers are asked to get on all fours to relieve the pressure on the umbilical cord. A second line option is transcervical amnio infusion. This involves using an infusion catheter to infuse saline into the amniotic cavity, and sometimes by increasing the amount of fluid around the baby, you can get a temporary improvement in the variable decelerations. And then ultimately, in all these cases, you need to consider an operative delivery, either an operative vaginal delivery or a cesarean delivery if the decelerations do not improve. So when I was a med student rotating in OBGYN, I was taught the mnemonic veal chop, which I'll pass along to you now. This is a way to remember the causes of the different types of fetal heart rate changes. So variable decels are caused by cord compression, early decels are caused by head compression, accelerations are benign and are okay, and late decelerations indicate placental insufficiency. Let's talk a little bit about fetal heart rate variability. So the heart rate in the baby should go up and down a little bit, caused by activity of the sympathetic and parasympathetic nervous systems. Normally the heart rate varies from 6 to 25 beats per minute. Marked variation is considered more than 25 beats a minute, and if there's absent variability, this is an ominous finding that indicates fetal distress. And you can see some examples on the screen here of absent fetal heart rate variability, normal, and then marked over on this end. And here are some zoomed in examples. We have minimal or absent fetal heart rate variability in this example here. This would be an ominous finding that indicates fetal distress. Down here we have moderate variability, and up here we have marked. A rare pattern on the fetal heart rate tracing, but one that you should definitely know for your board exams, is the sinusoidal pattern. This refers to a sine wave-like pattern with regular amplitude and frequency. This is an example of one shown on the screen here. You can see that the fetal heart rate is going up and down like a sine wave. And this finding is very rare, but when you do see it, it's an ominous finding associated with poor outcomes, and it's usually due to severe fetal anemia, and this is what you want to know for your board exams. Clinically, fetal heart rate patterns are often divided into 3 categories. Category 1 is good. This is what you want the baby to have. It's a baseline rate of 110 to 160, which is normal. There's moderate variability, and there are no late or variable decels. Remember, early decels are very common and benign. Category 2 is in the middle, and then at the other end of the spectrum is Category 3. So fetal heart rate tracings considered Category 3 may show recurrent late decelerations or recurrent variable decelerations. They may also show fetal bradycardia or sinusoidal pattern, and these are all elements indicating significant fetal distress. So some of the management options for women in labor and delivery who have a fetus with a Category 3 pattern are shown on this slide. First of all, the mother is often given oxygen and IV fluids to try and maximize delivery of oxygen to the fetus. We already talked about how changing the maternal position is a key intervention, especially in women with variable decels, to try and relieve any pressure that may be present on the umbilical cord. Because uterine contractions can cause placental insufficiency, oxytocin is usually discontinued if it's being administered, and sometimes a tocolytic like terbutaline is even considered to stop the uterine contractions altogether. And then ultimately, when the fetal heart rate tracing shows a Category 3 pattern, you have to prepare for operative delivery, either an operative vaginal delivery or a cesarean delivery. And that concludes our module on intrapartum fetal monitoring.